Hey, good evening, everyone. My name is Kristen Alex. I'm a nurse practitioner, and I'm joined tonight by Stephanie Wilson, who is also a DNP nurse practitioner. We are excitedly both in Mountain Standard Time, so finally get to collaborate with someone on the same time frame. So it's about 5 o'clock out here, and we want to thank you for joining us tonight for our January Society for Vascular Nursing Roundtable. And if you don't know, the roundtables were kind of born out of a need to have continuing education webinars and roundtables with panelists sometimes, and to just give our society members and anyone who wants to learn about vascular disease kind of like a quick little, like updates on things. And this is all being part of the education committee through the Society for Vascular Nursing. So shameless plug. If anybody would like to join the education committee, I, along with Sarah Rosenberger, who I think is on, I see her name on the screen, is with me, and we're doing some very exciting things within the society. So after this roundtable, if you like what you heard, if you're energized and have some extra time, it doesn't take a lot. We meet 1 hour a week to join our committee. We'd love to have you. We're doing some really fun things that you don't need to be a master's prepared person. You can be someone who's passionate about vascular disease and give us great insight. So for those of you who don't know me, I'm the past president of the Society for Vascular Nursing, and I am very passionate about nursing education. That's why I've stayed on to help with co-chair in these events. So I hail out of University of Colorado, and I work inpatient, outpatient. And with that, I'll turn it over to my co-person, Stephanie, to introduce herself.
Thanks, Kristen. My name's Stephanie Wilson. I'm a nurse practitioner working in vascular for the last 4 years. I work for Pulse Cardiovascular Institute in Scottsdale, Arizona. I'm part of a practice with one busy surgeon doing both inpatient and outpatient work. And I'm so excited to be here. Thank you guys so much for having me. This is my first participation in a roundtable discussion.
And I'll let you know how this kind of worked out. I was at a education seminar sponsored by Silk Road, and Stephanie happened to be doing the presentation. And I said, "Oh my gosh, you should come talk for SVN." So I finally got her. So Stephanie, go ahead with your disclosures.
Hopefully it's the first of many, actually. I disclose that I'm a paid consultant for Silk Road Medical, which is now Boston Scientific. However, I'm not being paid for this presentation. This was on my own will.
Yeah, and thanks for that. A lot of good things happen when you volunteer, and especially volunteer your expertise, which I'm very excited about tonight. I want to just thank Silk Road, just regardless, they are a big advocate for vascular nurses, vascular APPs, and they're modeling basically how executive health and industry is helping kind of push education forward. So even though they're not with this, but you will see their name come up as they are proud sponsors of SVN. So our goals for tonight are going to evaluate imaging for patient with carotid disease, discuss indications for an operative intervention, describe the history between the two types of repairs, discuss risk of repairs and postoperative nursing considerations of each type of disease. So this is kind of there's no real patient, but we want to start out with like kind of a case presentation. So I'm Kristen, as I introduced myself, but I work at a small hospital. I work with a vascular surgeon, and he has 30 years of experience as an open surgeon. He does not have a ton of endovascular skills. He is kind of aged out of that technology. You can do an angiogram of the leg, but he was doing femoral stents or transfemoral stents. We work at a rural hospital with a C-arm in our OR suite, and that's how we get our angiographic imaging.
And for this case, I work in a large teaching hospital. We have a general surgery residency and a dedicated vascular fellowship. I have 7 surgeons in my practice, ranging from 1 to 30 years of experience. We have 6 hospitals, and 3 of which have hybrid ORs. So we are quite advanced in our endovascular techniques.
And this is perfect, because one of the things we like to highlight here is that there's a lot of patients that need carotid disease. And it doesn't matter if you live in a rural hospital or if you live in a um, central, metro facility, you're going to present with the same kind of disease. And so now we're going to present our patient who's an 82-year-old woman. She's a past medical history of hypertension, hyperlipidemia, and some orthopedic issues, but nothing, she hasn't had surgery yet. She doesn't have any renal or cardiac history. She's a former smoker. She quit when she was 75, but has a 45 pack year history. Patients, she presented with an episode last week when she could not speak or move her right arm while at dinner. This lasted a few minutes and then she returned back to normal. So she thought she should mention this to her PCP. So Stephanie, does this anything stick out about her? Is there anything more you want to know?
Yeah, so I think with this baseline information, we can see a few important things, which is she has a couple important risk factors: hypertension, hyperlipidemia, and a history of smoking. She does not have renal or cardiac history, which is good, but certainly we would want to know more about her history, and then I'm sure her PCP is going to want to start a workup for this episode that she had.
And that she did. And I was struck by the same things. And if I were to put this in a documentation, I would say this was very classic symptoms for a TIA.
Absolutely.
Um, so in my head, as I'm reading over that history, I might have put a different picture of a patient in my head. I might have thought, oh, 82, she's home, she's got all these problems, she was a smoker, I might have put it in my mental head before I even went into that to that room, like someone who was kind of old and frail. But this is how Alice looks. She's very active. She lives in a senior community. She recently redid her apartment with the help of a designer, so she's not going anywhere. She's got long-term plans to stick around. She plays bridge 3 times a week. She swims and does water aerobics 4 times a week. She tries to stay as healthy as she can. She takes care of her grandchildren. And the other information I wanted to know are the two big things when we're taking care of anybody with atherosclerotic disease is what kind of medical management they're on. And appropriately, her primary care doctor has turned around aspirin 81 daily and rovastatin 5 milligrams daily. So,
That's pretty impressive for only two meds for a 82-year-old with that history.
yeah,
Pretty, pretty
it certainly
impressive.
was impressive. So, why don't you walk us through, Stephanie, what her primary care doctor kind of ordered for her?
Okay, so Alice's primary doctor, like us, said, "Wow, this is pretty classic of a TIA," and he contemplated sending her to the hospital, but it had been, over a week since it happened, and so he went ahead and ordered a carotid duplex ultrasound. He may have heard a bruit on his exam, or may not have. I'm not sure, but he did follow with a carotid ultrasound. So what we're looking at here is the tech worksheet. We didn't include the actual images to the ultrasound, but this is a tech worksheet of someone in Alice's situation. What we're looking at, those numbers starting, you can see the bottom of that picture is the aortic arch, and then you've got your innominate, your subclavian, your carotids, and your left subclavian. These numbers that we're being given are velocities. They're the flow through the artery measured in centimeters per second. And how I like to describe this to patients is the higher the number, it equates with a faster moving blood. So if you think about putting your thumb over the end of a garden hose, the more you pinch the garden hose or cover the end of it, the faster the water goes and the farther it shoots. It goes with much more force. And that's what we're seeing when we see higher velocities in the carotid, is that that's indicative of a stenosis with these higher velocities. So you can see on the right side, you'll see numbers of 64, 65, 80, but on the left side, you see numbers of 330, 227, or 277, and 174. So those velocities are high, and you can use that table on the right. Most vascular labs have criteria that they use for putting people into categories of how much stenosis there is based on velocity, and then also based on ratio, which I'll mention here in a second. But Alex, tell them your example. I liked yours. I use the garden hose to think about it, but Alex uses something different.
Yeah, I usually say if you have a river and the river's just flowing gently along, and all of a sudden there is a beaver or any sort of debris in the river, or something that's blocking the river, it takes that slow, gentle stream down to a very fast moving and rapid stream. So that will pick up, much like the velocities do here, as you can see in the internal carotid artery on the left.
Exactly. I like that. I always try to use things that patients can sort of relate to. Otherwise, they'll look at this and they'll say, what am I looking at? What do you mean it's greater than 70? But how much stenosis is there? So I always think it's helpful to pull out the table, sit down with the patient and say, okay, so the highest velocity in her left proximal internal carotid is 330 centimeters per second. So if we use our table that's greater than 230, so that shows that it's a greater than 70%, but less than total occlusion. And then the ratio, I think, is another very important thing. The ratio is a comparison between the velocity in the ICA and the CCA. Anything over 4 would be indicative of a significant stenosis, greater than 70%. And then the third factor that goes into this reading would be the end diastolic velocity, the EDV. Anything over 100 is indicative of a severe stenosis. So this patient, no doubt about it, with her velocity of 330, the diastolic of 104, and then the ratio of 6.1, she is certainly having a severe carotid stenosis.
Yeah, I really like how you said that too. Those are my 3 markers of the things I look for. That a measurement over 300, the end diastolic over 100, and then that ratio over 6. And patients always ask me, like, why do we have this criteria that's so wonky, like 0 to 49%, 50 to 69%, 70 to 99%, and then occluded? Like, why can't they just tell you I have a 45% stenosis? And I don't have a lot of answers for that, other than I know your flow changes. So anytime your flow is 0 to 50% occluded, even in your toilets at home, your velocity or the flow is not going to be impacted. So I don't care if it's 33%. What I do care about is, now that it's over 50% narrowed, that there's going to be a change in the flow going through that. Under that, no change in the flow. So the same perfusion. So
Exactly.
moving on. So we move forward and we got some more imaging.
Yeah,
So
so
Stephanie's going to walk us through this.
Alice ended up having a CT angiogram. This was ordered. She had an urgent referral to a vascular specialist when her PCP got a call about the results of that carotid ultrasound. So she was sent immediately for a CT angiogram. So what we're looking at on the left side of your screen here, these are the axial images. So we're slicing the body, I don't know if you can see me, this way through sections. So you can see the lungs there. And then I don't think, you guys can't see my mouse on the screen, can you? Can they see your mouse, Kristen? Probably.
I have a mouse
Okay, you
on the
show
screen.
So show them the aorta and then that there's contrast there. And then go ahead and start the video. And I'll sort of talk through as we're playing. So going up towards the patient's head, you'll see the great vessels take off there. You have both of your carotids. You want to pause for a second? Yeah, there you go. And those are common carotids, the right and the left. Now we're paying close attention to the left side. And if you blink, you might miss it, but there was a severe stenosis in the left internal carotid. Right there.
I missed it.
Yep, right there is where it's tight.
That.
Exactly.
Right there. So she's still got some flow through it, right?
Exactly, yep.
Yep, and then it gets big. And you'll notice too, there's some post-stenotic dilatation after that area of stenosis, and that's a very common finding for patients with narrowing of their arteries. I'm going to move over to this one. What can you tell us about this?
This is the sagittal views. So we're looking at the side. You'll kind of recognize. You'll see her facial structures there. Pause there. You'll get a good view of that post-stenotic. You'll see the stenosis right there, and then the post-stenotic dilatation going up into the ICA. So that's the lesion in question. What we can say looking at this is already we can tell that this is not a very calcified, there's is not a calcified lesion. There was maybe like one speck of calcium in there, um, towards the closer towards the bulb, but the lesion itself looks to be relatively soft plaque. It does not really look ulcerated. It looks fairly smooth to me.
Trying to get to a real good picture right in there.
Yeah.
I hope
But you can
everyone
see
can see
that
that.
dark. So on CAT scan, anything dark in a artery like that is more of a softer plaque, and anything white like bone is calcified.
Yeah. All right. So now we got our imaging. Alice is doing well. She's on appropriate medical management. So now we're going to start the discussion of how do we do stroke prevention for someone like her, because this is a lesion that would require a surgical treatment. The question is, what type? So now we're going to talk about surgical planning. And the thing that stands out to me, Stephanie, that because she's had her TIA, I would put her in a symptomatic category,
I would agree
correct?
with that. Absolutely.
Yeah. And what are the indications for surgery? A symptomatic patient is someone with a recent TIA or stroke, and they have a carotid stenosis greater than 50%. And an asymptomatic patient, meaning no TIA or stroke, greater than 70 or greater than 80%, is someone we want to intervene on for stroke prevention. And I'll let you talk about since you're the TCAR person, the things that you're looking at when you're looking at these very important CTA, head and neck, when you're thinking about TCAR for this patient.
So we've talked about indications. Next comes to anatomy. This is all stuff that's happening before, possibly before you even meet or see the patient. When the patient first becomes known to you, I think these are the four big factors to consider. For anatomy, though, you will want to look at your available imagings, whether it be ultrasound, CT scan, or even MRI can give you a lot of information. Some things to keep in mind are, is this a high lesion, meaning is it closer to C1, C2? It's going to be very high on the neck. Is it a low lesion? Is the bifurcation or the lesion much lower? Is it calcified? Is it soft plaque? Is it thrombus? Does the patient have a hostile neck? So some of the anatomical requirements specifically for TCAR. So TCAR is a product that has a specified IFU. So in order to, I mean, sure, a lot of people do things off label, but if we're speaking strictly on IFU, you have to meet these four criteria to use the system. You need to have a common carotid artery greater 5 centimeters. That is a typo. That's 5 millimeters. Oh no, 5 centimeters from clavicle to lesion. No, I was correct. So you
That's
need
a
to have
length.
a long enough when you have your clavicle here to your lesion, you need to have enough space. So 5 centimeters from where your incision is going to be to the lesion. Now this is the typo. Your common carotid needs to be greater than 6 millimeters in diameter, not centimeters in diameter. Your common carotid should be free of disease. And the reason for that is you need to safely put the sheath in order to go on flow reversal and perform the procedure. If you have disease where you're trying to access or where your sheath needs to go, you can embolize, and that would be potential for cause of stroke. And then there's IFU specifically for the stent, and that's a internal greater than 4 and less than 9 in diameter. Some comorbidities to think about when you're considering TCAR versus CEA is their surgical risk. So their age, have they had head and neck surgery, radiation, a prior carotid endarterectomy with restenosis, a surgically inaccessible lesion, and then their medical risk factors. Coronary artery disease, heart failure, have they recently had an MI? Do they have a history of a cranial nerve injury from something? And then their pulmonary status, because those all play into their surgical risk and deciding what procedure is best for which patient.
Yeah, and there's a big medical consideration too, right? The last thing.
Absolutely. Absolutely.
Yeah, so I'll move forward to the next slide. So I'll, kind of tell us the pros. You kind of got to it when you were talking of TCAR, and then I'll go into the pros of CEA.
Sure. So TCAR is relatively new when compared to carotid endarterectomy, but it's sort of a hybrid between endovascular principles and surgical principles. The if we were to just list the pros, I mean, truly it is a smaller incision. Generally, patients have a shorter recovery time. There's been some quality of life surveys that show that kind of one of my favorite things to tell patients is 75% of people after a TCAR are back to driving within 1 week. And I think it's 25% are back to driving within 1 week of a carotid endarterectomy. So are they going to have a good long-term outcome? Of course. But for someone like Alice, who is active, she may care about, her recovery and getting back to her lifestyle quicker. There is a low risk of stroke and heart attack. There's there's a tenfold lower risk of cranial nerve damage with a TCAR compared to a carotid endarterectomy.
Mhm.
There's data, and we'll go through some of the data slides in a little bit about patients with that the TCAR can be safer if somebody has severe coronary artery disease or pulmonary disease, as well as chronic kidney disease. Generally, it's a shorter procedure time and a shorter hospital stay. Oftentimes, it can be done completely under local patient awakening.
Wow. Nice. And the flow reversal concept also protects the brain, and we'll get into that as well.
So this is mostly the same information, but the reason that TCAR has gotten such good numbers, not only in their studies but in the VQI data, is that you're avoiding, because transfemoral carotid stenting has been around for a long time, and we all know that the trouble that was with that and the stroke rates. But by doing a TCAR, you're avoiding the aortic arch. You're not traversing the real danger zone per se. We know that a stent is durable and effective, but there were issues with transfemoral carotid stenting. And then there are issues with carotid endarterectomy in terms of risk for cranial nerve damage, etc. So
Yeah.
I think I put a picture of the flow reversal in here, but it might be in here somewhere.
Well, I'm sure we'll get to it.
Yeah.
So same thing, kind of, right, for stroke
Yeah.
risk?
However, there's exactly very similar stroke rates, and I think that's where we'll see that later. But nothing is without risk. I mean, if you're doing any intervention on a carotid, there's risk of stroke. So no matter which way you look at it, there's still risk of bleeding, hematoma, and infection. It is still a surgery. There's all the risks that come along with anesthesia, especially not every center is doing them under local. So a lot of are doing them under general anesthesia, and you still carry the same risks as you would for CEA. There's still risk of stroke, death, and MI, though it is relatively low. Another risk of TCAR, it needs to be, patient selection is very important. I always say you can do a carotid endarterectomy on anyone, but I mean, there may be more risk for certain patients, but you cannot and should not do a TCAR on anyone. Lesion morphology is very, very important. If you have thrombus in the carotid, or if it's a heavily calcified lesion, you're going to have poor success with TCAR. Thrombus, while you do have flow protection, if you think about the struts of a stent, the thrombus will just squish into the lumen and eventually embolize and cause a stroke. And then a heavily calcified lesion, you don't get good expansion of the stent. And then the last thing that I say, I put it under risk, is if a patient cannot take dual antiplatelet therapy, it doesn't have to be Plavix and aspirin. It can be Brilinta or Effient or one of the other P2Y12 inhibitors. But if they cannot stay on DAPT for 30 days post-op without interruption, you should not do a TCAR. It is not safe to do it not on DAPT.
That's a big thing. So, wow, look at this thing.
Oh yeah, had to throw the pictures in there. I know, but the pictures of CEA plaque are pretty impressive, aren't they, Kristen?
Oh yeah, we'll get there. Don't you worry. But yeah, this is all in your embolic protection device on the
Exactly.
sheath,
So when you're
right?
getting the flow reversal, you're having retrograde flow through the carotid. It comes down through the NPS system, the neuroprotection system, and particles can get trapped in this filter before the blood is then returned back into a low pressure system, which is typically the femoral vein.
Wow.
It's patients do sometimes ask, are you taking the plaque out? And it's like, no, we're not intentionally taking plaque out with a carotid stent. you're essentially covering it with a stent, but you do get particles. And I don't know about you, Kristen, but I'm not sure if I feel better when I see something in the filter or when I don't see something in the filter.
Right. That's a great point. Great point. So I would say if someone was going to make the argument to be at my hospital with my surgeon who's done, you know, carotid endarterectomies most of his career, why would they want to have that? And I would say, carotid endarterectomy is one of the most durable procedures originating in the 1950s. So vascular surgeons, this is one of our bread and butter kind of procedures. I like to tell people this is our hip replacement. We just do it all the time and it's very standard. We're always doing it for stroke prevention. I used to have a surgeon who said, you have a risk of stroke with the procedure, but if you don't do the procedure, your risk of stroke is 100%. So no need for Plavix typically with this procedure. Of course, every surgeon, caveat, asterisk, is different. Sometimes they like to treat with dual antiplatelets for 30 days. Really depends on their risk factors and their symptoms, I think. There's typically a low risk of restenosis with good risk factor modification and medical management. And I've probably, in my vascular career, which is about 20 years, I've probably seen a restenosis of a carotid probably 10 times. These are heavy smokers, or they didn't get the Plavix, or they didn't get the Lipitor, they've done nothing to risk factor modify, or they just kind of had bad luck. So, but typically it's a very durable operation. Again, it removes the plaque buildup from the carotid artery, improves the blood flow to the brain. I've had some people tell me, I don't know about you, Stephanie, but they'll say, oh, I can think more clearly. I
Yeah.
can, I don't have that brain fog anymore, which we always take credit for, but we can't say is medically, we medically did
Exactly.
that.
I always, the joke my doctor likes to make when they say that after is, oh, good, I'll send you a second bill.
That's funny.
So we never
So
promised it, but certainly people say it.
yeah, for sure. And it's pretty durable, so it can last the lifetime of the patient. Obviously, this is an older person's disease process after, years. I have seen, people need a carotid endarterectomy for traumas, for misadventures, maybe with or if someone's had a dissection. But at the same time, this is an older person's kind of disease process, so this will outlast them, hopefully. Um, the risks of the carotid, here's a beautiful picture of the plaque inside. You can see it's being pulled away from the intima. And the things that you can see kind of in the corners is what we call a shunt. And depending on your surgeon and how they trained, they can put a shunt to kind of shunt blood around our two sites, so the patient's always getting some sort of flow from that side. Now, remember, the brain is a siphon and it has a circle of Willis in the center of the brain. So if someone has a carotid stenosis on one side, but a patent carotid on the other side, the risk of, the brain having, an ischemic stroke by not having enough blood flow is usually very low. They usually have an embolic stroke because something had broken off, sadly, during the time, like we showed in that great video.
Kristen, can I
Or
interrupt you for 1 second?
sure.
Do you want to? That kind of leads me as to why getting a CTA head and neck is so important for preoperative
Right.
planning. Do you want to comment on that?
Yeah, I would say that having that the where your carotid bifurcation is in the neck, usually C2 and lower is kind of where we can do these open repairs, because if the lesion is very high, you actually have to really, for exposure, really torque on that incision and on those nerves. And I'll show you a picture of the nerves in the area.
What
And
about a
that can lead to
contralateral
outcomes.
occlusion? Because you
And
were
a
speaking about,
contralateral occlusion.
circle of
Yeah.
Willis, and because I think the reason I guess it rang to me was my surgeon only uses a shunt if there's a contralateral occlusion or a severe intracranial disease, something else that's going to.
Sure. Yeah, no, it's a great point. I'm glad you
Don't
brought
skip
that
on
up.
the head and neck. The head is important.
Right, exactly. So, bleeding, of course, this is a big incision. There's risk of bleeding, especially when you're patching, especially when you have blood pressure variability. We'll go into that. Risk of death is less than 0.5%, I think, but it's usually caused by the risk of anesthesia, stroke, heart attack. Very low infection rates. Saying that, I've seen 2 infections in a carotid endarterectomy. Pretty scary when it happens. And then the other complications, like you touched on, with the general anesthesia. So post-procedural stroke rates, Stephanie, you want to talk about this? about the studies?
Sure. This is a slide that I got from Silk Road, permission to use. This under the high surgical risk, the orange square. It has the studies that were used to get approval of the neuroprotection system and the carotid stent that is used. So throughout the course of their studies, Proof, Roadster, Roadster 2, you can see that they're having very reproducible low stroke rates, 1.3%. So in the Roadster and Roadster 2, you see PP and ITT, so per protocol and intention to treat. Meaning if you follow the recipe just like how you basically should be able to get a 0.7 or a 0.6% stroke rate, which is some of the lowest ever documented in any carotid intervention historically. But what I really like about this is the VQI data, because it's real world data. We're not talking about, people who are cherry picking patients and, are they perfectly on IFU? Are they a perfect surgical candidate? Though these were all high risk patients. But the VQI data is excellent. And basically you can get equivalent stroke rates between TCAR and CEA at 1.4%, which are low, very low stroke rates. And then that led to what's on the right side of your screen, which is for standard surgical risk patients. As we know, CREST was a trial, oh gosh, many years ago now. But the transfemoral stroke rate was 4.1%. But when you look at the VQI, TCAR, and CEA, you have 1.4 and 1.1%. So excellent, excellent low stroke rates for both TCAR and CEA.
Which is great.
This is very similar, but Roadster 3. Was anyone part of the Roadster 3 study in your site, Kristen?
No, I don't think so.
We were part of Roadster 3. It was a prospective study for the TCAR device for standard surgical risk patients. So again, very low, 0.9 in the intention to treat and 0.6 in the per protocol groups.
Yeah, that's why it's getting just a ton of attention. So this highlights kind of the same thing with MACE, right?
It does, but I guess the only point I want to really make about this is saying that if you have a program that offers all carotid interventions, medical management, TCAR, CEA, even transfemoral, I guess, that your program has a 10% risk reduction for overall MACE. And I'd say the reason for that, because you look at that and you're like, well, why is that? But I'd say the reason for that is when you have every option available to you, you can make the appropriate recommendation or decision for the patient. Because not every patient is perfect for TCAR and not every patient is perfect for endarterectomy. But if you don't have both options available, you're probably you may offer them the wrong or the higher risk operation. So I like it.
Yeah, that's a great slide. I used to say, as a vascular surgeon, you have many arrows in your quiver, so you have to choose the right thing for the person. So
do you want to speak on this or shall I guess.
Go ahead. Yeah.
The point here is, and we sort of touched on this with transfemoral stenting, is that there are pitfalls. You have to cross the lesion unprotected. You have to cross the arch, both of which will increase your risk of having a stroke. But if the stent is delivered safely, which in the TCAR operation, you're having reversal of flow and clamping the carotid before you cross the lesion. You'll get those patients who say, oh, I don't want a stent. I had a stent in my leg and it closed down, or I had a stent in my heart and it didn't work. But the point here is to say that the carotid is a different territory. And there are many, many studies out there saying that you have your 10-year data for CEA versus TCAR in CREST showed that you have basically the same stroke-free survival and the same equivalent patency at 10 years. So it's very durable as long as it can be safely delivered in the right patient.
And appropriate medical management. Correct?
Correct.
Yeah. So this is the same kind of data we were just talking about when they looked at, this is a slide from the Journal of Vascular Surgery, and this came out in 2018, where they basically compared the outcomes, and they're pretty similar for CEA and CEA and carotid artery stenting. So if you go down looking at stroke, acute MI, death, and then again at 5 years. Very, very similar. So to your point on the MACE study you just talked about and having surgeons kind of being able to offer both, this kind of, just shows us these same things. A lot of people talk about cost effectiveness, right? Like how much does a TCAR cost versus, plain old surgery? There's a lot of, steps. There's a big stent you have to pay for. You've got the whole device system. And they thought about this too. And I had to look up this QALY, which is quality of life, of year-long life, which means like, are you living in a healthy fashion, like in a year? Like how healthy can you live? I'm probably explaining that wrong, but it's something like that. But these were also very similar. So even though the 5-year cost was a little greater in TCAR and carotid endarterectomy, people are still having the same kind of quality compared to CEA, but this cost effective ratio was a little bit higher. So you just had to live long enough for it to catch up, I guess is the point of the slide. So there's also like an impact on age. We thought we would say, you really want to pick your patients well when you're offering surgery. Again, this is a later generation in life, a type of need. So 80 being that number that everybody does a question mark, do they have a good 5-year mortality if you're going to intervene on the carotid? In analysis case, the answer is yes, right? She's very active. She's, been doing things that are very good. So this TCAR versus CEA, there were really no significant outcomes for the impact on the age. With transfemoral, it was a little bit higher, which we've already proven in another slide. But anyway, they've kind of studied this right up and down, which we kind of wanted to show you. So for those nurses at the bedside taking care of these patients, anytime you have an intervention, be it CEA or TCAR, you're going to have, things you're watching out for. You're going to pretty standard is neurovascular checks every hour. You want to evaluate the site, the incision. You want to have adequate blood pressure management. Both of these patients, and maybe we're getting away from this, will have an arterial line as we get towards the shift of these patients that are kind of on the healthier end going right to just like a not ICU but a step down unit for post-operative care, and then their medical management, right, watching their blood pressures. Anytime you will go into this intervene on a carotid, you're going to mess with the baroreceptors, and you want to make sure that you're able to see if that stent or that incision is really bothering the baroreceptors in a way they're making your patient hyper or hypotensive or tachycardic or bradycardic. And you want to make sure you can respond very quickly for that. Stephanie, this is to your point that TCAR without DAPT is not a safe procedure. So we're always making sure that our TCARs are getting, either one of the antiplatelet agents. Anything else you want to say about that?
No. Next slide shows basically combinations of you can use aspirin plus Plavix, Brilinta, or Effient, and the doses.
Nice, nice. Because there's a lot of people that will say, "Oh, I'm allergic to that," but there's other agents you can use.
Absolutely.
So yeah. So it's just like our patients with statins, we can always move towards safe, effective statin administration. And that's very important for our patients. So obviously complications are about the same. Stroke, we've talked about, cranial nerve damage. We've talked about a little bit, hematoma, infection, hypotension, bradycardia. It's a little more common with carotid stenting in my experience, hypoperfusion and hyperperfusion, which we'll get into here. I'll let you take over, Stephanie.
Okay. Are we doing questions at the end, or should we address questions as they're coming in?
I see 3 questions.
Couple popping in is why I saw it pop up.
Okay, if you can
We
read
can do
them,
them at
go
the end,
ahead and
maybe.
address them
Yeah.
because
Oh,
I think I'll screw up my screen.
okay. Um, the first question was, what's the optimal timing from TIA symptoms to a surgical repair in a symptomatic carotid stenosis? Typically, I hear 2 weeks. Treat within 2 weeks of a TIA. Kristen, do you guys practice differently?
Yeah, I would say 2 weeks to at the very latest a month.
Month,
Like, but
maybe.
we're really trying to get that because the 30-day incidence goes up within that 30 days. So of a repeat. event. So
Second question was DAPT. Do you test for Plavix responsiveness prior to starting DAPT? I do, and I could tell you the reason why, and it was for a patient. I did not used to. I used to put everybody on aspirin and Plavix, and with my first acute stent occlusion after a TCAR, the patient actually had discharged home and came back the same day with symptoms of a stroke. And we did a CT scan, and he had acute stent thrombosis. He had been taking his aspirin and Plavix the way he was supposed to, and it turns out he was resistant to Plavix. It was then that I learned we even had the option to do the testing. But I always kind of hold that close because I feel like had I known that before, maybe I could have prevented it. He ended up doing well long term, and he's made an excellent recovery.
oh,
Um,
thank goodness.
but I do routinely do it. I start everybody on Plavix, and I use Verify Now P2I12 test, and I will just switch them to Brilinta if they're resistant.
Nice. Nice. We have not been doing the testing. I think there was like a push for it early on, and then there was some question of not being able to get the test, or if it was expensive, or
Yeah,
it wouldn't be done in the period of time that we needed it to it. So, I mean,
yeah.
I think we could be better about it for sure.
I love Verify Now. It's a point of care test, I believe. They can do it. It's done relatively quick. I'll even do it on same day of surgery sometimes. I try to have them come in a day or two before so I can appropriately load them, but I do sometimes have to do it on day of surgery. I had spoken to some nurse practitioners I think they were out of California at one of the hospitals, and they were routinely doing their Plavix resistance testing, but they were having to mail out the samples to Mayo Clinic in Arizona to get the results.
Oh, wow.
And so it was taking like a week. So I can
Yeah.
see where, especially in a symptomatic patient, that you don't want to be spending so much time looking for, whether they're resistant or not. It can impact the patient's timeline.
Yeah, it's a really good point you bring up.
Okay.
But
I
yeah,
guess,
thank you for that.
yeah, I wanted to get those questions quick. Okay. So we're talking about complications of TCAR and CEA. So hypoperfusion injury is when generally you have a low blood pressure and you'll see watershed infarct, which is ischemic damage between major arterial territories. So these are not people that embolized a piece of plaque from their carotid or from their stent or something, but you can get an embolic shower in multiple territories. Low blood pressure is probably the number one cause of this, and we see it, I'd say, more common in TCAR than CEA. Go to the next slide. I think it was on there. It had a statistic about. No, not yet. Okay, I think it might be the next one. But basically, you want to avoid hypotension. That's how you're going to prevent it. So close blood pressure monitoring. Kristen mentioned these people generally have an arterial line, and they're being watched either in like a step down unit or an ICU with strict blood pressure parameters. All right.
Yeah, it's a big deal for carotid endarterectomy too, because having a low blood pressure, if you can imagine, can also occlude your carotid.
Good. Yeah, use
So
your patch. Yeah, for sure. Though I think it was saying it's 15% more common with stenting. And that's because with carotid stenting, you're putting pressures on the baroreceptors in the carotid, and then continuously that stent continues to put pressure for can take 24 to 48 hours for them to acclimate. So things that we can do in the postoperative period is make sure they're adequately hydrated. These people are coming in dehydrated. They're elderly. They're probably not drinking enough to begin with, and then we make them NPO. So making sure that they're hydrating well the night before their NPO status, holding ACE and ARB on the day of. A-line monitoring we talked about, and then a big one is actually early supervised mobilization. So everybody thinks if you have a low blood pressure that you should not get the patient up, but in this situation, it actually, as long as it's supervised and you probably have medication on board at that point, it certainly can help reset those baroreceptors.
I did not know that. And there's a big push right now in a lot of hospitals to get people early mobilized just so we
Yeah,
can,
there's a
kind of
lot
get
of
them
good
going.
benefits. Yeah.
hmm for sure. Um, then we can talk about hyperperfusion when your blood pressure is way too high. So this is the loss of the brain blood brain barrier. Let me say that again. And these patients are actually so. I like to say we just open the floodgates. They're
Mhm.
more typical. Anybody's at risk for this, but they're more, particularly more at risk, is if we went from a patient with like a total collusion and had a string sign on the side we're intervening, or very high lesion, and now we just open the floodgates. And the when you see a reperfusion edema or a hyperperfusion syndrome, you'll never forget it, because these patients are languishing. They are having a horrible headache. They have blurred vision. They are often writhing in bed. They need all the lights off. They're nauseous. It's kind of like witnessing someone with a very high ICP, because that's exactly what we're doing for them. So as you can tell, if we don't catch this early in the management, they are very much at risk for hemorrhagic stroke. I was rounding one day on a 25-year-old who had FMD, and she just had a carotid to aortic bypass. So she had aorta, carotid, aortic, other carotid side. And she had initially done well, but then her blood pressure just kept creeping up and creeping up. And we had to put her in the unit for a good week, trying to decrease her blood pressure until she equilibrated. But if you think of an FMD patient has very narrow carotid arteries as it is, and then you just give them two big bypasses, what that can do. So yeah, I don't think I'll ever forget it. So post-procedure blood pressure management is a big deal for both of these. Hypotension after carotid artery stent is adverse neurologic and cardiac events, which we talked about, and very much high mobility, the same thing we've been saying. It should be anticipated, but not feared. And that's why these patients are often getting 1 hour neuro checks, and they're in a place where you can monitor them. Here's a very nice schematic that Sarah added about the slow trickle of flow for a near occlusion of that carotid with the arrow on the left, and then what we did with the tidal wave after we put that stent in.
Same
So you
idea
can
with your
imagine
bypass
what,
patient.
yeah, what the brain is going through. And remember, the brain is a closed unit, right? All you have in there is blood, brain matter, and cerebral spinal fluid. And if you increase one of those, it offsets the whole cerebral perfusion pressure. So good things to watch for. Um, and then predisposing factors to this. I thought this was a great slide, if you can talk about that.
Sure. You sort of touched on this about the people that are at risk
Yeah.
for hyperperfusion injury, but you're looking at the people with bilateral disease or a contralateral occlusion, intracranial small vessel disease, a recent stroke, or people with sustained high blood pressure post procedure. So we generally don't want them above 20% above their baseline for more than an hour. And then the non-osteal stenosis. Now the reason for that is sort of like we talked about with the stent putting pressure on the baroreceptors. Well, that's in the bulb of the carotid. So if you have a non-osteal lesion, like an isolated ICA lesion, and you stent it, you will not get that compensatory response with the lower blood pressure and heart rate. So they'll continue to probably be. It's an example of carotid stenting where they typically will remain hypertensive after, as opposed to having any lowering of the blood pressure.
Yeah. And I think one of the big kickoffs is, headache in these patients. And I tell all the nurses, any headache doesn't respond to Tylenol, I need to know. And they're typically going down for CT scans or in the unit getting good blood pressure control. So just want to put it out there, like the slide says, nausea, vomiting, just like I described that girl, non-focal, they can get to obtundation, seizures, and then the hemorrhagic stroke. So like I said, I've seen this very, very rarely in my career, but it's always good to have in the back of your head. Like we mentioned, 20% above baseline was systolic above an hour. What can we use for this? Esmolol drip, IV nitrates, that's why they get to the units, nimodipine, IV dexamethasone, at predilation, then 4 mg after, and that just kind of calms the brain down. Um, I just thought, since we had all these pictures of the carotid artery stenting, here's a beautiful picture of a carotid surgery intra-op. This is someone who had a TIA, Mount Alice, but you can see here that looks like a very unassuming carotid on the left side. And then you kind of open it up during your longitudinal incision, and you see that kind of binguba of that carotid plaque. The picture of it after the endarterectomy, and you can see this was an ulcerated ruptured plaque, and this is what caused the TIA. I've heard it described as someone like if you go over a pothole and the blood is, with your car and you hit that pothole, you can spray and throw emboli or debris that's in that pothole north. And that's what's exactly happening in a stroke. And that's a very nice picture of a carotid patch that was put on there with the sutures and just kind of how the post looks. Why the carotid endarterectomy, is the reason why the TCAR was born is because of all these structures in that open space and the retraction that we have to use to glean that exposure in the neck. If we're pulling on, if you have a resident who's maybe tired and not paying attention to the case, and all of a sudden he's retracting way too much, you can get a lot of stretch on these nerves. And they'll present with, if they have a hypoglossal injury, tongue difficulties with speech, they feel like they sometimes can't feel the side of their mouth. They'll chew or they'll bite the inside. Sometimes they have hoarseness. If they have a vagus, they'll have vocal cord paralysis and they'll speak in a whisper. And this is really frustrating to patients. Facial, sometimes they droop of the lip. Now, this is a big thing, especially with a medial mandibular nerve. When you get that guy, which is very common, know that if you have a droop on the same side as your carotid endarterectomy, it usually means we've kind of dinged a nerve. But if you have a droop on the opposite side of your carotid endarterectomy, that should raise some red flags that they're actually having a postoperative stroke. I have seen that happen, and I learned one of my favorite vascular words after watching this. The resident sent me to discharge a patient, and they had this droop, and they all said, "Oh, it's from the retraction." I said, "No, no, no, it's on the opposite side. It's his stroke side."
Oh,
And I said, "He's not going anywhere." And we rescanned him. And what we found is he had a recrudescence of symptoms. And that's the vascular word, which means that area that had been damaged by an ischemic stroke had now been revascularized. And it kind of stimulated that area. So it brought back some of his symptoms. It was nothing to do. The patch was okay. We did a CTA and ultrasound. Everything looked great. So anyway, really good to see. This is the scariest probably thing that personally I haven't seen, but I've heard tons about, of a hematoma of a CEA. Obviously, we're keeping these guys slicked up on platelets and blood thinners and sometimes heparin drip if we're doing it for thrombus. So to see something like this can be a surgical emergency and should be recognized right away. If this happens and it compromises the airway, typically you'll have stridor, you'll have tracheal deviation, and these patients will often get decompressed at the bedside by sticking a scalpel in that incision and draining that is compromising that airway. And then they go to the OR to have them re-washed out. So good thing is Alice did fine no matter where she went. She had a great surgical outcome. And I think for me, the key takeaways for APPs, both working with carotid patients and bedside nurses, was really just knowing what your complications are and kind of thinking through, like, how did they choose to do a carotid versus carotid artery stent. But we, as the bedside nurses and the APPs taking care of the patients, should be very well aware of the risks and ramifications of these patients. Stephanie, any closing thoughts from you? Thank you
no,
for your expertise on this.
oh, absolutely. Thanks for having me. I agree. I think, the most important things are patient selection and then postoperative management. I mean, we have the opportunity to, as an APP and a bedside nurse, to make a difference in the patient's outcome. I mean, we can give the surgeons credit if we want, but really we're the ones who change the patient's outcome.
Yeah, and I'd like to give credit to Silk Road for recognizing that. right out of the gate
Mhm.
and hiring people like Stephanie to come talk to nurses, come talk to APPs, find out where the sticking points were. And they did this very long time ago. And they really, like I said in the beginning, they're champions and advocates. And with that, if there's any questions, we'll take them. I don't think I see any different questions in the chat. So with that, I'll yield back about 4 minutes, and thank you for joining this roundtable tonight. And I appreciate you coming. Have a great night. Thanks again, Stephanie.
Nice.